Okay, so right side of the heart was practically the forgotten ventricle, but it is not anymore now. And I would be talking about that and about the latest guidelines which we have now. So, by and large, people have been doing eyeballing to assess the right side. In fact, generally, people omit right side of the heart, do not comment on that when they are doing echo. Just comment on the left side, don't comment on the right side. And if somebody by mistake comment on that, it is just by eyeballing. So by eyeballing and quantitation, you see the various studies have shown that quantitation clearly outnumber the qualitative assessment of the RV. So we have to do it by qualitative methods. So why RV matters? Because of the key clinical impacts of the outcomes in the pulmonary hypertension, heart failure, congenital disease, and ICUs. So RV failure is practically a prognostic bomb, and RV dysfunction predicts mortality independent of left ventricular ejection fraction. In fact, our cardiac surgeons are really afraid because whenever they see right ventricular dysfunction, they are really afraid to go in. And this is how the world sees it. The right ventricular size and function. Most of the European labs, majority of them academic hospitals, and size of the RV is done by only the basal diameter, and rest of the parameters are done very rarely. Similarly, the function of the RV is done by TAPSE, and the rest of the parameters very, very rarely. So this is how the world sees that, and this is how majority of the people in Pakistan are also doing it. So important thing is that we must do the TAPSE very properly. We have to align the angle very properly, and if we can use anatomical M mode to measure it properly, that would be nice. And similarly, very dense echo of the tricuspid annulus should be used for measurement. But we must remember that interpretation of RV function is not just TAPSE because of the complex geometry, crescent shape and heavy trabeculations, longitudinal shortening and radial thickening, and all other effects. So we have to do the TAPSE or the S prime, RV IMP or T index, and I generally prefer a tissue Doppler measurement of the IMP if I am doing that, but generally that is not a very favored kind of reading for RV analysis. Fractional area change is an area which should be done routinely by everybody, and we have to do the fractional area change by RV focus view. Normal is more than 35%, and this is one of the recommended methods of quantitatively estimating the RV function. Whenever we are doing it, we have to include the trabeculations and bands inside the chamber. So this is one of the methods which is in the guidelines as well. Now, another new concept, that is the RV-PA coupling. This reflects the relationship between RV contractility and PA afterload. This is a key determinant of RV performance and prognosis. Gold standard is ease by EA, that is an invasive measurement, and the surrogate is an echo-based assessment of TAPSE by PASP ratio. This has got strong correlation with invasive RV-PA uncoupling and prognosis, and the normal, which has previously been like about 0.5, now the recent guidelines say that 2025 guidelines say that it should be normal cutoff is 0.31. We can do TAPSE by PASP, or if we can't get the pulmonary artery pressure or TR is not there, then RV fraction area change can be replaced in the numerator, S prime can be done, or longitudinal strain can be done. So all these methods are emerging parameters. Some are investigational, but presently we rely more on TAPSE by PASP. So why it matters? Because it is an early marker of RV dysfunction in pulmonary hypertension, heart failure, and ICU settings. It predicts outcomes better than RV function alone or PA pressure alone, and guides therapeutic decision making like pulmonary hypertension management or RV failure. It shows how well the right side of the heart works against the pressure in the lungs. We can do global longitudinal strain or 3D imaging, but that is going a bit beyond the scope of present presentation. So we must remember there are certain red flags in RV dysfunction. If we see IVS flattening eccentricity index is there with pulmonary hypertension, that is a red flag. If you see McConnell sign, that is pressure overload, that is a red flag. If you see with right-sided enlargement, pericardial effusion, that is a red flag. And IVC and right atrial pressure, if it is increased, that is a red flag. So to conclude, RV is vital. It's sensitive to loading conditions. Echo is practical, but multimodality is ideal. It's important but challenging because of the complex geometry and coarse trabeculations. Eyeballing is not recommended. Qualitative assessment is recommended, especially for RV, subtle kind of RV dysfunction. We must use multiple acoustic windows and RV focused views. We must also always do RVPA coupling by TAPSI by PASP. And especially we have to be careful post-cardiac surgery when the TAPSI is generally reduced because of a pericardiectomy. So we should use a fractional area change. And we must remember that if RV fails, the patient may fail even with a normal LVEF. We have very recent guidelines in March. These are the American Society of Echo guidelines on the right side of the heart. And the important points in these are that the mean PA pressure has been reduced to 20 to tell about the pulmonary hypertension, and they have followed the European Society guidelines. We must look by the RV focus view. We should do the TAPSI as prime and fraction area change. Strain in 3D whenever applicable should be done. And the hemodynamic assessment, right atrial pressure, systolic pressure of the RV, pulmonary artery and diastolic pressure, pulmonary vascular resistance, RVPA coupling, all these things should be done. And lastly, for hemodynamic calculation, RV outflow tract acceleration time, which was not done in the last guidelines or briefly mentioned, now they are recommended. Pulmonary vascular resistance, which was not done previously, is not recommended. And RVPA coupling, which was not mentioned or included in the previous guidelines, it is very strongly recommended in the recent guidelines. I think I have finished in time and the recently allotted time.